have an hour, but I really think we won't take that long. I plan to have a panel, but because of flights, some people got to leave. So that's fine. I know what they would say, so I'll just say what they were going to say. But there's a lot to accomplish. I'm also going to announce the poster awardees as well. I'm going to do a little bit of reflections and roundup from the conference and what I'd like to see going forward. But before I do that, yeah, I'll do some reflections. I'll talk about why it's so important to champion women's health research. I think you probably got the message about that already. And we really need to cherish this valued community. And we need to band together and, ensure that we ride the current recognition that women's health research really matters. But before we do all of that, I want to first bring to our collective attention a fantastic success story that came of someone paying close attention to women's mental health variable, and that was postpartum. And you got a little glimpse of that from Yulia Sacher's talk, and I'd like to call up CAMH's own Dr. Jeffrey Meyer to talk about his, oh, it's not up here yet. I thought you were putting it up while I was talking. Oh, you were to talk about a randomized, double-blind, placebo-controlled trial of a novel dietary supplement to prevent postpartum blues. First one ever. Pretty amazing.
Well, thanks so much, Liisa, for inviting me. Not only did Liisa and the organizing committee put on a great, couldn't really be a better conference, really set a high bar, which I think we should give a round of applause to. But they also decided to be super current. So I published a paper just last week in eClinical Medicine, which is really a major advance in developing a novel supplement for trying to prevent postpartum depression. And I'll elaborate further on that. And then just a week ago, I published this, and then they said, well, can you talk for 10 minutes at the conference? So I'm delighted to do so. Yeah. So just to clarify, when I'm talking about postpartum blues, what I'm talking about are the symptoms that happen in the first few days postpartum, typically peaking at day 5 and happening in about 3/4 of women. That includes things like crying, sad mood, anxiety, restlessness, decreased appetite, and may also include things like low energy and difficulty with sleep beyond the difficulties of taking care of a newborn. Now, while unpleasant, these symptoms are considered within the healthy range of experience. But the reason that they have an importance clinically is that when they're severe, they increase the risk for clinical level postpartum depression by at least 4-fold or more. So there's an opportunity, if one can think a bit about how to reduce these symptoms, as perhaps a way to prevent later postpartum depression. Just in terms of conflicts of interest and whatnot. So I'm the inventor of a supplement that I'm going to be talking about, and CAMH owns the patent, and then CAMH licensed it to Exeltis, and as of last week, Exeltis has made this available in the United States, and the hope is that it will be available in many countries in time as we develop it further, and each country has its own regulatory requirements for these sort of things, which of course we would respect. So I'll backtrack a little bit. You heard a little bit from Julia Sastre the other day on topic when she was a postdoc fellow in my lab. So monoamine oxidase A is what the supplement is intended to be countering. And monoamine oxidase A is a protein found on outer mitochondrial membranes, often found in astroglia, as well as neurons and monoamine-releasing neurons. It has a role in reducing monoamine, so that's particularly of interest in mood disorders. And we developed an imaging technique, 11-carbon harmine PET, to look at levels of an index of levels of MAOA in the brain in a number of conditions and illnesses that have depressive symptoms. So this would include major depressive episodes, a number of conditions where perhaps one might be at risk for major depressive episodes or have subsyndromal symptoms, not quite reaching necessarily a major depressive episode level. And built up quite a body of literature on this, but I'd like to elaborate in particular on a direction that relates to MAOA, and that it's been known for quite some time that there's an inverse relationship between changes in estrogens and levels of MAOA, messenger RNA, and MAOA activity, which has been shown across cell lines, rodents, macaque monkeys. And it's probably related to changes of estrogens affecting estrogen receptors and some crosstalk affecting estrogen-related receptors, which have influences on MAOA transcription. And we've heard plentiful comment, and everyone seems very attuned to the points around declines of estrogens after the placenta is lost in the first few days postpartum. And so this is the similar kind of graph, just quantitative, actually derived from the studies. And after these drops in estrogens, you can see around day 4 to 6 is sort of a point where things start to level out a little bit. And so I designed a PET imaging study to look at an index of MAOA levels at day 4 to 6 postpartum, which you saw some data the other day. So on the y-axis, we have the index of MAOA level, and across the various regions, you can see that there's quite a rise in MAOA protein level in women who were recently postpartum as compared to women who are not recently postpartum. And in PET imaging, 40% magnitude is about as big as it gets. So this is a very large magnitude kind of effect. Throughout the gray matter regions of the brain in which MAOA is found, this finding was also established on a voxel-wise level. And one can think about this as a bit of a model for understanding postpartum blues. So we have this strong decline in estrogens, which is well established, a very large rise in MAOA protein level throughout the gray matter regions of the brain. And it would be presumed that if MAOA levels are elevated, that some of the functions that MAOA have would also be elevated in terms of greater serotonin metabolism across the gray matter regions of the brain, greater metabolism of norepinephrine and dopamine. And in the process of metabolizing these, it produces hydrogen peroxide. And so one would consider these as potentially involved in mechanisms leading to postpartum blues. So I invented a dietary supplement that's composed of tryptophan, a precursor to serotonin, tyrosine, precursor to norepinephrine and dopamine. And as well, I included antioxidants that were taken from blueberries, anthocyanins. Anthocyanins are about the right molecular structure to get in the brain, and they've been radiolabeled in rodents and shown to cross the blood-brain barrier. About 2% of the total distribution volume gets into the brain. And tryptophan and tyrosine are already known to cross into the cerebrospinal fluid. There's been studies that have demonstrated this. So the supplement is a simple strategy in terms of the effort it takes to do it. It starts in the night of day 3, and it's 4 dosings going to the morning of day 5, and each dose has antioxidants, blueberries. And then on the night of day 4, we have tryptophan, and the morning of day 5 has tyrosine. Another advantage of using tryptophan tyrosine from this point of safety is that they're already in breast milk. So we did studies to show that tryptophan and tyrosine don't affect the total levels of them in breast milk because, as I said, they're already in breast milk, but we empirically showed this. So on the left, you've got the graph showing what happens in the blood of women taking tryptophan, and on the right, you can see that the total levels of tryptophan don't change. We did a similar study for tyrosine as well. So I'll go on and just show a few highlights from the randomized double-blind placebo-controlled trial of the supplement. We'd done an oral study, or probably an open trial previously, and then the blinded study came out just last week. Not an easy study to do during the time of COVID. As you can imagine, running trials in that time can be quite difficult, but nevertheless, we were able to pull this off, and I'm very appreciative of the teams that were involved with this. One of the team members here, Rashmi, is part of the team, is here. There was about 15 authors who all worked quite hard on this project, and it could be 10-minute talk just on the efforts of doing a trial in the midst of COVID, but I will move on nonetheless. So the 2 important times for the measurements are at day 5, which was the measurements of the postpartum blues and a depressed mood induction. And then the other measurements that were important were measurements of overall depressive symptoms, which were taken just shortly before taking the supplement and then extending out to 6 months. So the first finding was the mood induction. Now, unfortunately, I think in the context of the mood induction, it didn't quite go so well when we adapted it to bring into people's homes. And I think there were baseline effects in the mood induction, which led to it throwing off. So we had a negative finding in the terms of the mood induction, where women would read these sad statements and listen to sad music. And we didn't have a change between the active and the placebo. However, in terms of overall postpartum blues, we had a favorable effect of the active over placebo. So you can see in the active, the histogram, you can see that the frequency is mostly shifted to the left, that those that got the supplement tend to not have very many postpartum blues symptoms. And you can see the vertical red line representing the medians And so there's a significant difference in terms of the mean with the general linear model as well as the median. So that was the main finding of the study, and then the conclusion being that there's an effect on postpartum blues. Now, with supplements, you've got to be thinking, of course, about tolerability or any intervention for that matter. So tolerability was quite favorable. It was interesting when the students were sending out and my research analysts were giving me back the data. I was like, well, we have less symptoms in those that are actually taking the supplement, So people were quite blasé about that, but I was quite excited. So what we do is everyone gets a list of questions that we ask everyone. They're probably symptoms more related to being postpartum than they are necessarily as an adverse effect attributable to the active or placebo. And it's turned out that there was a tendency for those who got the active to be less likely to report any adverse event. So it was a trend that way. It was probably largely related to less headache, less drowsiness, and less restlessness in those who got the active. So tolerability was great. The other thing we looked at, and I mentioned before about the connection between postpartum blues and then later postpartum depression, that postpartum blues is really potentially an opportune window to intervene in order to reduce symptoms of postpartum depression later. And so that we explored the issue of depressive symptoms over time. And what you can see is that before the supplement, the levels of symptoms of depression are about the same. And out to 1 month, they're pretty similar. And then there's this divergence such that those that got the active went towards to a reduction in depressive symptoms as compared to those who got the placebo. And this is the same data but shown as a histogram. So in the upper corner, you can see that the distributions are pretty similar between the active and placebo. This is pre-treatment. And then out at 6 months, you can see that the active generally have not so much depressive symptoms. Placebo, there's a group that are actually in the clinical range that we don't have in the active. So I think that's a very promising finding, no question. So I've walked through quite a bit in 10 minutes. Or 10 minutes, 32 seconds, I see. So what I've shown is that first that MAOA levels tend to be elevated in a number of conditions that either have a full-out depressive episode or might have subsyndromal depressive symptoms or at risk for having subsyndromal depressive symptoms. I've talked about a pathway towards translation about the dramatic drops in estrogens in early postpartum, which many have covered at this conference. What I've also commented on is the elevation in MAOA protein levels, which is quite dramatic between day 4 to 6 postpartum. Actually, in the study, if you focus on day 5, it's about 55% elevated. And if you consider that the PET imaging technique slightly underestimates that magnitude, it's really about 60%. So if you really want to build it up to get a real sense of what it would probably be if we could have got everyone on day 5 with the imaging method, it would have been even higher than where it was. And then as well, I've talked about the tryptophan and tyrosine, how they raise their levels in plasma after oral administration, but don't affect their total concentrations in breast milk. I didn't comment too much about the open trial, except that we had done one that with promising results. And then I've shown you the results of the double-blind trial, the randomized double-blind placebo-controlled trial, with the results from last week showing quite a favorable effect on reducing the severity of postpartum blues, with the implication being that if we could reduce the severity of postpartum blues, hopefully that can reduce dramatically the risk for postpartum depression later, with the promising data that we had less depressive symptoms in those taking the supplement 3 to 6 months later after that very brief time course of taking the supplement over days 3 to 5. So I can stop there. Just want to acknowledge there's quite a few teams that worked on the open trial and the randomized double-blind placebo-controlled trial, and those that also worked on the imaging project. So thanks so much.
We have time for questions. Anybody has a question? Oh, okay, well, I was gonna have one, but I guess.
This is very exciting, being an advocate for improved perinatal mental health services. So thank you for your amazing work and research. Just wondering if you know what the holdup is for Canada.
Well, every country has its own sort of, regulatory processes. So with the US, if it's been had a clinical trial, then it can go and be distributed as clinically tested. In Canada, Health Canada has its own sort of pathways for regulation, and so sometimes they evaluate the ingredients specifically, sometimes they will look at it collectively. So because the process is a bit different in Canada, they haven't had opportunity to see the clinical trial till last week. So it will take some discussion with them, and hopefully, they'll be upbeat about it. I think one of the issues that certainly emerges from a place like this conference is that sometimes different countries will have comments on how much tryptophan is okay as a natural health product, how much pyrazine is okay as a natural health product. But I think the question could be raised, well, why should that threshold be the same for males and females? And why should it be the same if you're immediately postpartum and you're female versus if you're in a perimenopause state and you're female versus a male who's 18 years old? Well, why should these all be the same threshold? So these are questions we would also raise with Health Canada as well. We'll see how they deal. But hopefully, even if grander vision and progress doesn't work immediately, I think that the very low rate of adverse events on the side that got the active natural health product should be helpful for their perspective.
You should. Hi, thank you, Dr. Meyer. I'm just wondering if you can speak to the value of commercialization. I think we've learned a lot at this conference about the impact of different things. I'm not a scientist, so I wouldn't call them things, but like, the gut microbiome and probiotics. And I remember we had a conversation a couple of years ago when you were doing this work about how it's very hard to say eat blueberries, but when you convert something into a supplement and market it, obviously it has some value. And so just wondering if you can speak to this sort of process of commercialization that you've gone through and how, the impact that you think commercializing this will have on actually getting it out into the world versus it being sort of a research finding related to.
Sure. It's a great question. And I certainly say it's eye-opening in the journey of doing this. So when we started with the technology transfer office was discussing with me, and we were saying, well, maybe we don't need to patent this. And we would go to, so we know that like the hospital wasn't going to be manufacturing the supplement and distributing it through Canada or the world or whatnot, so that it would take a company to manufacture and distribute it. And then when we go to companies, we would have them sign these confidentiality agreements, non-disclosure sort of things. And they all universally said, if you don't patent this, we're not interested in it. Because if we bring it and distribute it, someone else can just do exactly the same thing beside us, and then we've wasted all this time setting up, and we can't distribute. So the patenting was sort of essential. And I think the other challenge with patenting is that you need to have an angle that adds a certain level of novelty. And also, it's probably useful to have a lawyer who has expertise in natural health products. So CAMH has several lawyers, and they're all great at what they do. But the breakthrough was that the head of the technology transfer office happened to know someone in Ottawa, and she had a lot of expertise and experience with natural health products and understood more about how to patent them. And so the patenting, this is in over 30 countries, and I think that while it's not quite universal, it's enough that it should be able to allow a lot of distribution, which would be really helpful. So I think the patenting is important in order to find a distributor. And I think people mentioned about probiotics and whatnot. So I think the question is, if you're going to patent it, is there something you can do such that it would be then not readily duplicable? So, I mean, another company could try to follow the path that we did, and more power to them. It would take a few years to do it, and by then this would be available to people, and maybe there would be more available to people, and that would be fine. It's just, I think that to get a company started, they need to have some patenting in place.
So thank you so much. This is really exciting, and congratulations, Jeff. So I was curious about your take on whether you would want to do work in terms of understanding which risk groups might this apply best for, and would there be, is it yeah. Do you have any work in that direction planned or?
Right, so you know, as it's, if this study hadn't had a significant finding, then I think, you know, we would probably wouldn't necessarily have, it would be more difficult to go on to another step in terms of, so I think in some ways, the strategy of this study was to try to reduce the heterogeneity in the group that came into the study. So we selected women who didn't have histories of major depressive episodes to come in this study, because if you have a history of a major depressive episode, there could be a number of reasons for that that could create variability in the sample. And the thought was that the supplement was really intended to address the processes that and physiology that can happen in early postpartum. That being said, it would be interesting to look at the supplement in you know, in layers of higher risk states to see whether it could be helpful, you know, for women that might be at high risk for depression. Certainly, that could be an interesting angle. So yeah, that would definitely be another approach, or to combine it with other approaches potentially in women at very high risk for depression.
There are many other questions, but I did promise people we'd finish early, so I'm not, but I think that this is a really fantastic success story. And while I'm giving out posters, can you see if my gifts work, Pondy? Because it's not as much fun, but yeah, thank you. Yeah, of course. I think, you know, one of the reasons we wanted to highlight Jeff's work, and it was really auspicious timing that this came out at the same time, and I'm very sorry to the online community. I know you can't see me, but you'll see me in a minute. Thank you. I don't even know if anybody's there, but you know, it just goes to show you that paying attention to very susceptible periods in a person's lifetime to developing the blues and may turn into depression is really fruitful. So paying attention to these specific female factors can really yield valuable information. And with that, which I probably should have let other people ask a question, but something that I learned in a conference fairly recently is allopregnanolone. Many of you probably know, first time FDA for treatment of postpartum depression. This is prevention, right, of postpartum blues. But it seems to be, and I learned this from Inger, this seems to be effective in the postpartum, but might be the culprit, which I think we heard from others in this conference, for PMDD. So just because a specific a drug might work or hormone might work to alleviate a certain mental health outcome in one situation, one reproductive state, it might not work in another. And I think that's really important to underscore. It's not a one size fits all. Okay, before I get there, does it work? Do the gifts work? No, it shouldn't have to. You shouldn't have to push anything. Yeah, okay, doesn't matter. Doesn't matter. Nobody cares about my gifts. Okay, so it's now my pleasure to announce the winners of the poster award, and I'll stand here. So if you're here, can you please come up and obtain your award? You get a very nice piece of paper. Miriam Ali. Smile for the camera. Can somebody take our picture? Oh yeah, you want to see about, sorry, online. Thank you. I don't know if the next person saw it or not. It's Tashini Tiavakumar. Tashani, sorry. Tashani, is she here? Is she here? Is she here there? Oh, that's wonderful. Well, congratulations to Tashani. Sorry, I didn't say that properly. Aruba Mansour. Serena Phillip. Ian Yusefi Kusha. Smile for this camera and then we'll smile for that. You have to come a little. Hi. Hi. Oh, here's your things.
Yeah, a little bit on your.
Yeah, the font. There you go. Awesome. Thank you. And last but not least, and not at all in alphabetical order, so Emily May. Is she here? Yay, she's here. This camera, and then that
do the
camera.
same, like, hi over here.
And then- I think- And I just want to say congratulations to all of you. I mean, it was really an overwhelming response for the posters, and I hope we get to do this again and have many more posters there. I mean, you guys are the future, and we really do need you to keep carrying the torch and lighting the way for the rest of us. All right, so I might call upon one person that's here because the other two people are not here, but I'll do this at the end. I'm just going to try to wrap up with the 2.5 hours to 3 hours of sleep for 2 days and talk about some themes that I even talked about kind of at the beginning in terms of, the heterogeneity and what is normal and how come we always have to compare to a male standard. Think about that in terms of Megan's powerful talk, in terms of having autism as a woman and how long it took for her to be diagnosed. I put this up here because I hadn't seen many of these kinds of slides, but today, of course, we had some in the afternoon. But I'm putting it up just to say, hey, and this is just a very simple brain cloud. There are a number of neurological and psychiatric disorders that show sex difference in prevalence. But to me, what's even more interesting is that we see these manifestation in a number of these diseases and disorders. And I'm showing you scenes from my own family and life. And one of the things that you might have noticed is a lot of the blue higher prevalence in boys and men occur earlier in development, while the ones that are in the pink that occur more likely to occur in girls and women occur after puberty. That's when the big manifestation occurs. And so it's really important to have this across the lifespan approach. And many of you are probably very familiar with the fact that women are more likely to live longer than men, but they're also more likely to live with chronic illness. And that's my mother, who unfortunately passed away many years ago now, but she suffered from arthritis, endometrial cancer, as well as Parkinson's disease towards the end of her life. So a lot of issues with her chronic health, but throughout it all, she was a fantastic role model. I really appreciated this paper, but if you dig deep, I think it's supplement table number either 2 or 6, I'm getting confused now. In this particular, it's using the Danish registry. You'll see it's age of diagnosis, and there's 1,300 different diseases. And if you add them all up, human females have a delay in their diagnosis of 2 years. Now that's for the 1,300 different disorders. So then I asked Paige Reed, I said, take out all the ones that are just female, more of a delay, and add those up, and it's 986, something like that, of the 1,300, so 75% of disorders. This includes cancers as well, a delay in diagnosis. And if you just look at the ones that are female, 988 to 75, it's 3.7 years. And that's true for mental health disorders. That's true for depression, where you see a greater prevalence in females. That's obviously true for autism. It's even longer. Bipolar disorder. Anyway, there are many reasons for this. We've touched upon a number of them during this conference, both on the biological side, on the social side of things, on the dismissal of symptoms, that manifestation difference. And you often see this, right? These symptoms being atypical. Sorry. What did I do? I don't know what I did. Oh, the GIF. Oh, that thing again. The symptoms are atypical, right? They're described as atypical in autism, PTSD, stroke, depression, bipolar disorder. But I mean, that's because most of our medical knowledge and including our diagnosis criteria are based on the standard of what happens in males and the experiences of men, not what happens in 50% of the population. So it's not atypical when you're comparing, in women that our experiences is, it's just if you're comparing to men and that's standard. And I think we get ourselves into a problem when that happens. I also think when we're relying on males, we might not have and maybe this isn't the right analogy, but if you're trying to understand a disease and how it manifests or how to treat that disease, if we're trying, it's almost like you're trying to fix a refrigerator with an oven manual. Like it's just not going to be, some things are going to be the same. They're both an appliance. They both use electricity. But sometimes, like Dr. Sene beautifully showed us, they're in completely opposite ways. So our fridge keeps things cold while an oven keeps things warm, right? And so I think it's really important for us to continue to examine these kinds of factors. And what happens when you use sex-specific norms? So this is for a prodromal state to Alzheimer's disease. It's called amnestic mild cognitive impairment. About 50% of these individuals will transition to Alzheimer's disease in their lifetime. It is diagnosed principally through a number of measures, but principally through something called verbal memory, right? If you can remember a paragraph or a list of words. And it turns out that human females score better on this just normally. So are we missing people because our threshold is made for men? And it turns out Erin Sunderman, who, as Cindy Barha knows, is one of my superheroes, she looked at this. So she looked at retrospective data and she found if you could use sex-specific norms, you actually could improve diagnostic accuracy by 20%. You gained 10% more females or women and 10% fewer men. And think about that on a individual level, right? That knowing that you have a misdiagnosis or an inaccurate dosage, but also for you scientists in the room that love your biomarkers, if you don't have them in the right columns, you're going to have a lot more messy data. So this is why this is, I think, a beautiful illustration of why it matters. I got to show some of my own data because during the pandemic, we faced the same thing that many of us faced in labs, right? We couldn't get into the lab. And so I had 2 undergraduate students that were coming in the lab in the summer, and one of them sitting right there. And they were sad that they couldn't go and are you going to be able to afford to pay us? Do we get a job? And I said, yes, I've got something that you can just do at home. And so I got them to look at, pandemic, they were going to get into trouble if I didn't give those things to do. So I got them to look at 6 different journals, every single study that was published in 2009, 2019, that was over 3,000 studies they looked at. And they looked to see, just very simple, did they look at sex and gender? Gender, it was so low that we didn't even bother counting it. And these are the top, like the top or in the top 10 journals in neuroscience and psychiatry that are out there. But you can see a big increase in the number of studies or percentages of studies that are saying they're using males and females or men and women. There's a nice decrease in the number that tell us, like sometimes, often the older studies won't even tell you who the subjects were that they used. So you have no idea. So there's a big drop there. But only 19% use what we call an optimal design. And that sounds like, oh, well, what is Galea talking about? What does that even mean? We just meant, did they tell us what the sample size was? That was one of our, just sample size. And the other one was, is it relatively equal? Because sometimes it was not, it'd be 2 females and 20 males. Well, what's that gonna, by the way, I have a funny story about that, but that's for later. And then did they actually even look to see statistically if it made a difference? And look at that number, 5%. It's 5%. That's 2019. Oh, right. I think I was going to show that later, but it's up here now. Then we look to see how many were done just in males or just in females. And you can see it's a pretty small amount. And if anything, it's going lower. Now I've been asking, oh, that was in 2019. We've had SGBA, which in Canada is sex and gender-based analysis, since 2010. In the US, sex is a biological variable. It's 2007, 2016, it kind of came in, but it's, been around for a little longer, but that was when it was made mandatory, I believe. And we've had NIH, which is the big one, you guys know, and National Institutes of Health. The mandatory, you must add women to your clinical trials since 1993. So how many years is that? That's a lot of years, right? Still, it's a really low percentage. So why does this matter? We talked a little bit about allopregnanolone. We talked a little about a preventive treatment for postpartum blues. What about something like lecanemab? Lecanemab came out, I think, last year, first FDA-approved drug for slowing cognitive decline during Alzheimer's disease. Got a little bit of attention because there's some side effects, which I'd love to talk about more. It turns out it works okay in men. It doesn't work in women. It also doesn't work in Black people. It doesn't work in ApoE4 individuals, which have a much higher risk. 60% of people with Alzheimer's disease have the ApoE4 allele. So I'm very happy for the Caucasian men that are not at risk for Alzheimer's disease, that they have this drug, but let's find the drug that works for everyone else, right? And that's the promise of precision medicine. We can't assume that, human males are going to be like human females. It's like comparing apples to oranges. But I'd say that it's more than that. We have to remember there's many types of apples and many types of oranges. And I'm sorry, I'm using fruit, right? And we heard about diversity, right? Diversity matters. And we need to be able to incorporate that into our data. And, I don't want to push the women compared to men all the time, or males compared to females. We need to be able to study these women's health variables on their own, right? Pregnancy versus non-pregnancy, postpartum depression versus not, premenstrual dysphoric disorder versus not, postpartum psychosis versus not. That's a meaningful comparison. And I already showed you this data. There are 9 times more studies of males than there are in females. And when we did so you saw the 0.5% that Emily Jacobs did, that's on neuroimaging studies. This is on all time studies, just on the brain, not just neuroimaging. Those are the percentages that you see across all time. It's low, it's pitiful, and it's got to change. We looked at funding because SGBA and SABV, it's making everybody do it. No, and our bar was, did they mention the population? Did they mention what population they were using? They just had to say they were using females or women or gender diverse individuals. There were zero studies funded in Canada through this mechanism, which is our major mechanism, on two-spirit individuals. Zero in 11 years, zero. And you can see a very small percentage of female health questions. It's also true in the US. So how do we change this? We change this with investment in women's health research, right? World Economic Forum report, $1 trillion a year will save just by putting investments into women's health research. It increases, I always like that, if you build it, they will come, which is not what he actually says in the movie Field of Dream. He says, if you build it, he will come, but whatever. That's so patriarchy. No, it's about baseball players. It's fine. But so Ice Bucket Challenge, we know this is going to work. It worked for HIV/AIDS. It went from a death sentence to being able to live with the disease. Ice Bucket Challenge, 2014, they raised $115 million, obviously much more money since then. But since then, double the number of researchers working in the area, double the number of publications, 10 times on clinical trials. There are at least four new treatments for ALS that have been approved by the FDA in the last 3 years. That's because of the Ice Bucket Challenge. So we need I don't know, what do we want to call it? Like somebody said the bra challenge, but I don't know. Not all of us have, I talked about, instead of the Manhattan Project, can't we have a Toronto project, right? If we get together, we can build a weapons of mass construction. Can't we get together and build weapons of mass construction? So that's what Julian Einstein said. I wanted to call it an Eve bomb instead of an atom bomb, but do you see what I did there? Yeah. Okay. So I do think this would matter, but we need sizable investment. And what happens if we don't study these women's health questions? It costs lives, got this delayed diagnosis. That's a missed opportunity for early interventions. We know it matters if you have early interventions. I can give you many examples of that. And that ignores precision medicine. And it also costs the economy. So just it's a win-win on all levels. I've written about it. I wanted to show this just because I love that movie and it's a swear word and that's kind of fun to do when you're at a scientific conference. I apologize if you're offended by that swear word. But we need to prioritize. We lose so much. I'm happy to talk about it much more with you if you want. And as I try to give you an analogy, because often people want to improve healthcare, right, or improve access. Research helps with all of that, right? So if healthcare is our boat, our healthcare practitioners, including our physicians, are the crew, right? They can't get anywhere without the research to tell them where to go. And somebody said, what about wind, like the wind in the sails? And I said, to me, the wind is like politics because it can blow us in the wrong direction, right? So we need that compass and we need that map, and that's research. Research will tell us how can we make it more accessible, right? Maybe you need a different kind of dock. Maybe you need a different kind of boat to make it accessible. So research matters. And one of my dreams that could come out of this group that we have assembled, and we've already in talks about this, is joining forces. And you heard Yulia Sakar talk about sister hubs. I already hear conversations in the room starting on collaborations. You heard Emily Jacobs talk about her database. And you heard Birgit Derntel, which we can maybe make her come up here, talk about training programs if you're interested, because as a Mercato fellow, I got to listen to all of the PhD projects in Tübingen and in Uppsala and the great crosstalk between them. And it's just so much power when we can do that as a group. Right? It increases our number. It increases the more diversity on the team, the better outcomes. There's lots of great data. Better for your investment portfolios too, right? Those of you that are, I don't know if there's any investment bankers here, but right, diversify your portfolio and you have better dividends. So I really think protecting ring-fence funding would be really important to achieve these goals. I announced winners. I don't know if you have any questions for me because I'm gonna like end. Yeah, but you can always ask me questions afterwards as well. I need to thank, and I know we thanked them already, but I don't know if you understand how much work, especially Tiara and Jenna and Bonnie did. And I know how much because they were also texting me on the weekends and Friday nights. And sometimes I'd be like, look, I'm on my couch and I'm like falling asleep watching bad TV now. But it takes dedicated people around you to make things work. And they really did a great job. Also, all of the volunteers, a lot of them from my lab, I don't know if you want to stand up, but you did a tremendous job and many of you were voluntold and you've given up so much of your time, including Tanvi, who's like now our AV consultant. So if you could just stand up and we'll just give you guys a quick little. They're not going to stand up. They're here. They're not standing up. That's all right. One last thing, there's been a number of not one last thing, probably two last things. No, I think it's really the last thing. A number of special issues. So for those scientists, researchers, but actually anyone can write into the journal if you want. We're also having a special issue in Frontiers in Neurotechnology, which is not the open access journal. Frontiers, it's Elsevier, Pick Your Poison. I happen to be the principal editor, so I have a lot of sway at that journal, but they're due in like December to February. So and it will be all about women's mental health. So please think about that. And with that, I would like to thank you for listening, being patient with our AV issues. Thank you to those of you online, and let's build this global community.